Good afternoon, everyone. Um, uh, Very honored to be here to co-chair with Professor Yamakado. I think we will start the session and I will introduce our speakers. Today we have two very distinguished speakers. The first is Professor Toshihiro Tanaka. I think he is very famous. You all probably know him very well. From his CV, I noticed he has been with the Nara Medical University since undergraduate days. He did his radiology training there and spent a short time out in IG with Professor RI and then also 2 years in Europe with a research fellowship. He's currently professor and chair of the Department of Diagnostic and Interventional Radiology at Nara Medical University. So today he is speaking to us on a precise IR with high definition detector. I understand that this is quite new technology. Only a few centers are having this technology. So it'll be interesting to see what Prof. Tanaka can share with us. Professor, please.
Thank you, Professor Tay, for your introduction. I would like to extend my thanks to Canon Medical to give this presentation here today. My topic is on precise IR with a high definition detector. The Canon continued to evolving of angio-CT for the past 30 years. The currently most powerful combination is Alphenix Sky Plus with a high definition detector and combined with Aquarium 1. In Nara Medical University in 2019, Alphenix Sky Plus and Aquarium 1 was installed. In last year, 2021, we updated the Alphenix version 9.2. Before the talking about the high definition detector, I will quickly introduce the another functions: spot fluoro, auto registration, and auto table. First, this is spot fluoro. The spot fluoro provides a symmetric region focused on correlation with increasing the dose. The last image holds the outside of the ROI. This area is not radiation exposed. Next is auto registration. The 3D CT volume can be automatically superimposed with fluoroscopy. The obtained 3D image can be overlapped to the fluoro image. Next, auto table. Auto table can easy to reproduce the tabletop position. The reference image can be automatically changed to the C-arm position. Now, I will talk about the sensational innovation of Canon. This is a world first high definition detector. Before, the pixel size was 194 micron, and now is updated to 76 micron. The FOV was from 6 inch to the more than 3 inch. The more than 2 times higher spatial resolution compared to the conventional detectors. This is a phantom study using a line with 143 micron. You can see the obviously difference between the conventional high depth in the spatial and the contrast resolution. This is a human model. We use HCC feeding artery. We calculate these area. You can also see the obvious difference between conventional and high def. From now, I will show the several cases to show the usefulness of high def. This is a right gastric artery embolization. Now is using a conventional 6-inch FOV. The core is pressing, and the microcatheter tip is a push and back. This is a useful technique for to the compact coil embolization. Now switch to the 3-inch high def. You can see there are more detailed microcatheter tip movements. When we see the coil structures, high def shows a more sharply and high contrast of the coil. And also the coil structure also can detail we can see. Next, primary AVM. Paradoxical emboli are possible even with a smaller than 3 mm diameter. This means less than 3 mm also the indication of the treatments. Persistence due to recanalization through the previous placed coil. Therefore, sac embolization is recommended. And interestingly, small PVM had a high persistence rate, 21%, than larger than PVM, 10%. It may be due to the difficulty of the interventional procedure. We will treat this patient small primary PVM, 2 mm diameter here. As I mentioned just before, this is the indication of treatment. Now the catheter is inserted into the feeder. This is conventional 6-inch. Then we switch to the 3-inch. You can see very bigger. And now the coil is inserted into the sac and this tortoise feeders. Clearly see the embolizing the feeder now, 2 mm in diameter. Currently, the microcatheter technology and the coil technology can embolize these tiny vessels. And also, we can see the clearly seen this embolization. Now is placing a coil besides the previous coil. Perfect embolization. Next case, this is Dr. Okno's idea for the patient with pain due to the capsulitis. His paper showed angiogenesis might contribute to the pain, and we can see the abnormal vessel in the DSA. This is our case. We obtained the conventional CT and the high-def angio both. When compare the two angios, we can see clearly see the abnormal vessel in high-def. Another case, this is a thumb CM joint osteoarthritis. We can see the stain here in the conventional DSA. Then we took a high-def 3-inch DSA. When we compare these two DSA images, we can clearly see the tiny abnormal vessel like this, and also small shunt is here. Obviously different. Then we conducted the transarterial microembolization team using imipenem and cilastatin. The before embolization and after embolization, you can see disappearance of the abnormal vessel and also the microshunt. Next case, visualization of tumor vessel of SCC. This is a conventional DSA and high def. When we compare the two images, we can see the tiny abnormal vessel, tumor feeding vessel here. tumor vessel is functionally or constructurally abnormal, and angiogenic therapy it can improve functionally and constructurally. This normalization of tumor vessel can improve the drug delivery in cancer cell. This is a hot topic in the interventional oncology now. This is a patient with HCC, conventional CTHA and DSA show the tumor stain here. Then we are treated by rembatinib for 7 days. The vascularity is decreasing like this. Then we compare with in the high def angio. Before rembatinib, you can see the abnormal vessel. This is encased tumor vessel like this. After 7 days rembatinib, the encasement improved, obviously. Then we treated this tumor by TACE, immediately after TACE, and 1 month after TACE, dense lipid accumulation was observed. Next case, intraarterial infusion for liver metastasis. During the arterial infusion chemotherapy via port, the patient complained of pain and gastric ulcer appeared. When we check the CTHA via port, gastric wall was enhanced like this. However, in the DSA, we don't see the gastric branches. We already embolized the gastroduodenal artery and right gastric artery. Then we took a DSA in the conventional and high def. In high def, the gastro and duodenal branches are clearly seen, while there is no depiction in conventional DSA. Next case, superselective CTACE. In this 3D image, show the right blue and right green is already embolized. Now we are embolizing in the blue branch. This is conventional DSA. And now the microcatheter inserted into this branch. Due to the previous embolization of the tumor with the Ripido, it's difficult to see the catheter tip and Ripido. Now we change to the high def. We can clearly see the Ripido, and now the overflow here. Due to the stasis already, then microcatheter further advanced with the guide wire to this point. Then we are injecting the Ripido again with a semi-wedged condition. Nova overflow forcefully injected the Ripido. Very clearly seen in the high def. After taste, we can see the dense Ripido accumulation in the tumor. Now, finally, I will show the video case of PBM. This was conducted in just 3 weeks ago in our university. This patient was 40s female with HHT. 17 years ago, she received a colon embolization for 1 PBM. Now she has a total of 4 regions. In the right lung 2, and in the left lung 2. The reperfused region 1, new region 3. We take a primary angio. Already, right lung region 2 region was embolized. And now, we have 2 regions here, reperfusion, and the new region here. Firstly, we positioning the working angle using this reference device. One push button can see and move to the working angle quickly. Very useful function. Then now is using the conventional 8-inch. We are trying to recognize this already. 17 years ago, this coil was placed. The micro guide wire is now is here. It's difficult to see. Then we change it to the 6-inch conventional image. Still difficult to see, and looks the micro guide wire stop in the entrance of the coil. Then we switch to the high def 3-inch. More clearly see the coil structure. The micro guide wire is here, tip is here. And now go through inside the coil. We can see clearly. But now still stuck is here. Very difficult situation. And then I reshape the microcatheter like this and tried again using a high def 3-inch. Microcatheter guide wire tip is here. And pull back a bit. Then successfully recognized. After that, we embolize a sac like this, and also feeder as well, using the 6-inch. Then dense coil packing was confirmed by the 3-inch after embolization. Then we move to the next region, new region here. Using a 3D auto angle, we are looking for the optimal working angle, and then just push one button, the CR move to this working angle, referring 3D imaging. Very useful function. Then now is embolizing using a conventional 8-inch coiling the sac, and also using a 3-inch dense packing in the feeder. Finally, this is angio completely embolized. Next, in the next few minutes, I will explain the usefulness of Aquarium 1. Aquarium 1 has a 320 area detector CT and 0.275 fast rotation time, and also deep learning and reconstruction imaging ACE. I will show several cases. This case is a bronchial artery aneurysm with bronchial artery pulmonary adjunct. This is DSA. This is 3D CTA. 3D CT showed the vascular anatomy is clear. Aneurysm is here. And 4D CTA is here. This 4D CTA shows the complicated vascular hemodynamics. Next case, gastric varices due to spring vein stenosis. We can see that in the CT, gastric varices and cystic tumor in the pancreatic tail here. DSA is unclear the hemodynamics of the splenic venous flow. Then we took a CTA via splenic artery and obtained the 4D CTHA. We can see the stenosis of splenic veins here and the collateral flow to the gastric to the portal vein. This is called the left side portal hypertension. Next case, there are enderic after the EVER. The intravenous contrast enhanced CT shows the enderic here, and aneurysm is regrowing. But the origin of the enderic we did not find in the IV contrast enhanced CT. Then we obtained the 4D CTA. 4D CTA clearly see this origin of the enderic. Then we could diagnose type 3B enderic. The last case is uterine AVM. The MRI shows a complicated vascular surrounding the uterus. Then we took the CTA via aorta. For the CTA showed that clearly see the bilateral uterine artery communicated to the AVM, and also the ovarian artery connected to the uterine artery. In the 3D, we can see the connection points. Ovarian artery is connected to here, and the bilateral uterine artery is connected to here. This is my conclusion. High definition detector can achieve precise catheterization and embolization, which can simplify complex procedure. Area detector for DCT is helpful to analyze complex vascular disease. And these innovative technologies allow us to perform more complex and challenging interventional procedure. I appreciate the collaboration with the Canon team. Thank you so much.
Thank you, Professor Tanaka, for the very, very excellent talk. Very impressive images. I have two questions. For the high definition detector, you showed that you have conventional and then you can switch to high definition. So the detector is already inside the flat panel, both detectors, conventional.
Yes, already installed a high def detector in the center of the flat panel. Then they automatically switch to the center high def detector.
Right. So is it possible for existing angio machine just to install this, or you have to change the whole machine?
I guess changing the flat panel is needed. Do you want to install?
Yeah.
Yeah. Or install the whole new machine. That is good for you.
Yeah. The other question is radiation dose. If you use the high def, is it more dose?
Yes. That is we have to care and also choose the necessity of the high def. Not always use. Only the pinpoint, the critical point, like critical embolization, we use high def. The radiation dose is a bit up, but in advantage of the Canon is basically low dose radiation dose compared with the other companies.
Do we have any questions from the audience? If no question, I'll hand over to Professor Yamakado to introduce the next speaker.
Okay. It's my pleasure to introduce Dr. Alex Tang. and his speaker's title for this lecture is "Push the Limit of Interventional Oncology with Hybrid Angio CT." And he's Alex and me have been friends from 2008, so it's almost 14 years. And because Alex saw APSCVIR meeting in 2008, and he was 46 years, right? At the time of APSCVIR. And he has been important EC members in APSCVIR, and we talk each other many times. And perhaps you know, he is a very cheerful and very clever IR. And his specialism is in oncology now, but he has a lot of knowledge about for many diseases. So, Alex, are you ready?
Yes,
Yeah,
thank you,
please.
Yamakado.
Yeah. Please start your lecture.
First of all, I would like to congratulate you for as a president of APSCVR, and it's my great honor to be able to attend this meeting. I'm so sorry I cannot attend, I couldn't present physically because of some family commitment. I would like to share on my little experience on the hybrid angiosity pushing the limits in interventional oncology. These are my disclosure. And this year we are celebrating 30 years of success, and the equipment from this pub changer system to current state-of-art system of today's standard. And our good friend Tanaka has shared his work on the latest advances and amazing images he has shown and amazing work he has done. And this is my machine, which is already coming to 6 years old. And you notice that our monitor is a bit different. Your time, I will tell why I opt for the conventional system rather than the new beautiful screens. Well, hybrid angiosity offers solution to many issues which we face with the 2D angio, which is essentially the luminogram, with a lot of issues with overlapping tissue planes and angiosomes, has limited low contrast resolution of organs at risk, limited assessment of collateral damage, and we are not able to predict the central tumor ablation and deposition of embolic agents. And more importantly, with the current development, we are unable to evaluate on table on real-time information of 3D safety margins of the target embolization. This is an example of a case in 2006, which we thought that this was excellent work with dense embolization of the HCC. However, a month down the line, the tumor is still viable because the central core is still hypodense, and on the biopsy, it confirmed the presence of the tumor nest. On the other hand, with the new advancement and the hybrid angio CT system, the issue of 3D negative margin and embodied density could be easily ascertained. With the addition of CT cross-sectional arms, we are able to expand our visions and analysis of the target embolization in terms of region at risk, the 3D visualization, 3D angiography, the safety margin, and embolic density, which are very, very important. We are able to predict the outcome, and we are able to detect complication earlier, and the game plan may change from A to Z on the same sitting on paper. And we are in the era of 3D and 4D angiographic intervention, era of 3D planning and 3D guidance, and more importantly, the angiographic Google Map guidance. And we are able to see things we were not able to see before, seeing the unseen. And with the combination therapy as well as AI and image fusion, we can do a much better work. And these are some of the cases we have done, and we have many of these at our database. And this is one of the best innovation, the angiographic Google Map, which guides us to the target area of interest. Well, the minimum detector thickness in order to do this work, I will say that a 4 cm detector coverage is essential and not those 18 slides or 32 slides. And Tanaka's sharing of the Aquident 1 is obviously a dream machine for all the IR. And the reason of this is because if you have a small detector size, we have limitation in terms of G-axis coverage, and we always have this issue with G-axis aliasing and artifact, and because of obliquity, we cannot see the needle tip. And this could be properly profiled if you have a volume CT fluoroscopy. And with this single shot of those volume acquisition, we are able to evaluate the region of interest in detail, not only the multi-parameter plan. We are able also to do what I call it CT microangiography of the third, fourth, and fifth generation tributary with one single exposure. This is made possible by combining the CT as well as angiographic arms side by side and alternating one from another without moving the patient out of the angio room. And with that speed shot, I usually use hand injection at 0.35 seconds and 1 or 2 mils of contrast 2 to 4 second delay. We are able to acquire a very good CT angiographic images. Of course, if it's a non-vascular study, you don't need to inject the contrast. And the dose imparted to the patient is actually extremely low per exposure, depending on your setting. We call it 0.075 to 0.2 millisievert as compared with MDCT dose of 3.4 to 8.5 millisievert. And with this volume CT fluoroscopy, we are able to conceptualize a new dimension in terms of organ at risk identification, MPR assessment, and avoidance of G-axis partial volume artifact. With this technique, we are able to biopsy a 4M or 5M lung nodule at the base quite comfortably. And precise G-axis needle present is very important, especially when avoiding the critical structure like blood vessels or other organ at risk. And with this super selective target ROI analysis, we are able to see 3D safety margin assessment on table on a fly, and 3D coordination, device placement, and navigation, especially when we do the cardiac ablation in terms of needle placement and IRE. This 3D acquisition allows us to do the third, fourth, and fifth generation microangiography assessment, which I call it CT microangiography, and more importantly, the EMBO-TRACK guidance of this super selective study. These are all made possible with the power of hybrid angiography, and Wright has categorized his excellent invention. We all score A star throughout. Well, I would like to share on the real-life challenges as today, TACE in HCC. I think in the year 2020, Tanaka had raised his concerns on the diversion of intermediate HCC to commit the targeted treatment rather than coming for embolization. And this was the first SOP recommended in the year 2012 on BCLC staging, and in which TACE was the mainstay of treatment and a standard of care for intermediate stage HCC. But as today, since 2020, TACE dominant in this category is a past history. This is because of the APSCVIR consensus statement, which was published in the year 2020, where Shiro Miyama was in the committee in terms of changing paradigm for the treatment of intermediate HCC towards medical management. And second paper came out February this year by Masatoshi Kudo in terms of new treatment paradigm with systemic therapy in the intermediate HCC. Both these papers has severe impact for us as an IR. They have recategorized the HCC into two categories: TACE effective or curative, or TACE unsuitable. And the current treatment algorithm will be preservation of liver function, and the treatment goal is to prolong overall survival. This is in line to promote the medical treatment. And just to share the impact of CTACE, in this patient in the right lobe, a single session of CTACE, which I was able to put the patient into remission, but I can see that severe hypertrophy of the targeted area with a single treatment, even though it's super selective embolization. TACE unsuitable is defined as each one of the following three clinical conditions which prevent a survival benefit from TACE or condition that TACE is even harmful. That's number one, unlikely to respond to TACE, like loose conferencing multinodular type, messy or infiltrative type, or disseminated type, or subcutaneous type of disease. Second group are likely to develop TACE failure refractiveness for loose lesion bigger than 7 cm. This is by BCLC standard, but Apple standard they define it as more than 5 cm. In which, in this category, we take away about 90% of the workload in the TACE for his CC. And those are likely to deteriorate in terms of liver function, especially modified albumin and bilirubin grade 2B. And we further approval by FDA in terms of the use of atezolizumab with bevacizumab in the embrace trial for unresectable HCC. The oncologists came in a big way to take away more than 90% of our work. So at this stage, intermediate stage HCC will be divided into effective TACE of those less than 5 cm and TACE unsuitable, which are more than 5 cm. And with that, a lot of local regional treatment candidate has been diverted to the systemic treatment using lenvatinib. This was the initial stage, but with the atezolizumab protocol, all of them are being diverted to this immunotherapy as a treatment of choice rather than the thyroxine inhibitor. And so what's left for us? And this is the latest 2022 recommendation where all patients with 7 cm and above are diverted to atezolizumab or lenvatinib, where TACE come in as a supporting treatment or adjunctive treatment. The current scenario of health recommendation from the medical oncology arm, and this has coming a big way and win over the support of the clinical counterpart, is the ABC conversion therapy protocol. What is ABC conversion therapy? It is a first-line atezolizumab therapy for patients who have 7 cm above and claim that they are able to achieve 32.4% curative conversion therapy after the resection ablation or curative TACE. Essentially, they downsize it and undertake the resection ablation of curative treatment. And based on the current treatment strategy, IR are fighting a losing battle in this field. So what do we do? In my personal opinion, it's a new mindset. From now onward, we have to understand what is TACE suitable and TACE unsuitable and live within. For those TACE suitable, we have to ensure a complete remission with positive 3D margin and preservation of liver function in terms of intervention. For TACE unsuitable patients, we have to come up with new protocol to complement or to win back our cases, especially with the ABC conversion therapy algorithm. All these are made possible by instituting the use of hybrid angiography in offering super selective embolization, angiographic Google Map guidance, 3D safety margins confirmation, and CT microangiography intervention. Shiro Miyama has reiterated the criticalness and importance of concept of 3D safety margin in achieving a good clinical outcome, where the tumor is adequately embolized, and this is the embolized segment, and this is a diagnostic angel which shows the tumor is at the center of the area of interest, and this confirms the positive 3D safety margin. I would like to propose to Canon to come up with this software to make our life easier. And with the adequate or perhaps positive 3D safety margin, the 6-month recurrent rate is 29.1% as compared with 100% in those without. And this paper from Thailand, Kitipit also eluded the significance of the 3D safety margin with a 6-month recurrent rate of 11.3% versus 82.4% without. And the essence of the story is complete tumor stain and complete circumferential safety margin in order to achieve a good clinical outcome. Just to share with you, a patient who had microablation of 34 mm nodules, and 3 months later on a follow-up MRI, we detected 2 new nodules, and these were too small to pick out on the CT scan or ultrasound, and hence local ablation may be very challenging. So we decided to do a C-test, and using angiographic Google Map guidelines, we're able to selectively cannulate the segment 6 supply, and on table CT volume fluoroscopy confirmed the position of microcatheter and completion embolization with positive 3D margin, and similarly the other lesion lower down with selective embolization and confirmation of the positive 3D safety margin. And the patient had successful treatment and went into remission. Another patient who has a 5 cm SCC in segment 8, he has a non-anatomical resection, and again 6 months later there was significant local recurrence at the surgical margin. So in this situation, with the idea of liver sparing and prolonging survival, we are at a point where is this segment 4A artery supplying the tumor in the area of interest, because it looks like there's another small nodule. So we have no choice but to institute the use of CT fluoroscopy, volume CT fluoroscopy with a catheter cannulating the segment 4A and a snapshot showing that there is no supply. Hence, the segment 4 was not embolized, and the segment 8 was adequately embolized and densely with the confirmation of 3D safety margin. And this patient has successful embolization. This is a perfusion defect which was present since the beginning and no change in size. And notice that liver underwent atrophy over the area of embolization. If we are to embolize segment 4, there will be another bigger area which is devascularized. So it's very critical for us to institute super selective cannulation and minimum damage to the liver by avoiding overzealous embolization. Another patient who had a 8 by 7 cm HCC right lobe and a small left lobe with a background cirrhosis. Unfortunately, the surgeon was a bit more surgically friendly, who took the patient for an attempted liver resection, which was failed. Obviously, on table they have the abundant, and you can see that the surgical scar is there. This is 1 month after the failed surgery with a huge tumor right lobe. So we have to design a protocol in order to control this tumor with minimal damage to the rest of the liver. This is the hepatic angiogram which show a huge vascular tumor, and we decided to institute the super selective embolization using transarterial ethanol mixed with a cisplatin for chemoinfusion, and complete the 3D safety margin by using drug-eluting bed. And the target is to embolize the tumor deep at the center core with a 66% alcohol, then peripherally with drug-eluting bed. And one single session, we were able to achieve a complete ablation. And this was on table biopsy just to confirm that HCC as the alpha fetoprotein was not significantly raised. And this was immediate on table angiogram. We used cisplatin 50 milligram, doxorubicin 50 mg to mix with the tandem 75 micron and pure alcohol 26. This is at 2 years complete remission and 2.5 years complete remission. At this stage, he's still in remission. Notice that the right lobe has atrophied and the left lobe has grown. So in this particular case, we have rediverted the traffic flow from taste unsuitable to athesiobac, which would not attend such a good clinical outcome, and towards the taste which we conventionally do. So by the proper strategy, we hope we can win back more cases to the IR arena. Another patient who had rapidly progressing recurrent segment 7 HCC after surgical resection of segment 2 and segment 4. Angiographically, it's a bit challenging because the patient was started on lenvatinib. The feeding artery is very small, but with angiographic Google Map, we were able to segment out segment A7 supply and densely embolize, and 7-8 supply densely embolize. But on table, and he has also local recurrent segment 4A lesion, which was embolized, same sitting. And on table, CT completion CT scan showed a defect over the segment 7A. And the next day, we take the patient back to complete the ablation with microwave. So by combining these systems, we are able to achieve a very good clinical outcome. Another patient had hepatitis C with cirrhosis, Chalcus A, 6 cm tumor in segment 6 with 7-6 portal vein invasion, so his BCLC stage C. There is also another lesion in segment 7 superiorly. Because of the underlying limited liver reserve, we decided to use alcohol and right routing beads to take care of the bigger one and microwave the smaller one. Notice that on the diagnostic, DSA, right, hepatic artery, we do not see the AB shunting, but on the CT hepatic angiography, we see tremendous shunts. With that in mind, we decided to inflate a balloon over the right hepatic vein to prevent and cut down the risk of arteriovenous shunting and pulmonary embolization. This was achieved successfully, and we used 66% alcohol followed by drug eluting bed. And the patient went into remission, and it's already 6 years that he's still in remission. Along the way, I think there's some small recurrence which we ablated with microwave. Another patient, this is an interesting patient with 4 major surgery over the liver and 3 over the liver and 1 over the aortic dissection. He had a history of the NVA in 2004 with laparotomy, aortic dissection, and operation of done 2016 right lobe resection. And in the 2020, he has a small recurrence in 7.2, which was staged, but it failed. In April this year, last year, they went in and attempted the microwave ablation, but the microwave ablation falls short of the nodule. This was too anterior, and the tumor was growing bigger and bigger, invading in the pericardium. So they went in again to do another resection, which was failed, and finally was referred from another center to me for the angio-CT guided CT. This is the nodule which you are seeing. And on the DSA angio, you can see that right hepatic artery is near completely ablated because of the prior embolization in that particular center. And on super selective left inferior phrenic artery cannulation, you can see a lot of minute supply towards the abdominal wall. And maybe with Tanaka's new machine, we'll be able to see this better. And on the single snapshot CT volume fluoroscopy, you can see that a lot of supply of the liver capsule into the peritoneal cavity and some into the subcutaneous tissue. I think if we embolize at this point without organ protection technique, there is a high risk of skin necrosis. So I decided to prophylactically cut off the small collateral supply to the rest of the liver surface with a small amount of gel formed slurry and followed by dense embolization using CTAs. And immediate on table CT fluoroscopy showed that there was a negative 3D safety margin. So upon discussion with the referring doctors, we decided to insert a ferocious marker immediately on the same sitting and to carry out SVRT over the focus using the ferocious marker as a guidance. And this is 9 months down the line, his alpha fetoprotein was back to 2 nanogram per ml from 3,320. And he has complete remission. This was about HCC. I would like to share some of our work on non-HCC intervention. This was presented yesterday in the same meeting about our experience in transarterial chemosaturation in metastatic liver disease, where the transarterial therapy in metastasis come in a big way, and they play a lot of role in terms of salvage therapy and bridging or downstaging measure before focal ablation and surgery. This is a patient who had failed 4 lines of systemic chemo and referred for chemosaturation. This is after single session. We are going for the second session to clear off the remaining. This technique is play on the principle of high predetermined flow stasis after infusing the chemo drug directly into the area of interest, and is to enhance the cytotoxic effect. And we use degradable embolic in order to preserve vessel patency. And with this deep saturation technique at a concentration of about 500 times, comparing with the systemic chemo, we are seeing unbelievable clinical response in these cases. And all this made possible by the use of angio-CT guidance with super selective saturation and minimize the damage to the non-disease portion of the liver. And also, we emphasize the importance of 3D safety margin and embolic density. And so far, since the installation, we have done 481 sessions of days of chemosaturation, and the data in both analysis of 46 patients with CRC with a mean follow-up of 7 months, and notice that 89% are for salvage treatment with failed systemic treatment. And the majority of them have third and fourth line treatment, and I'm missing. The majority have 2 to 3 cycles of chemosaturation, and we have objective response rate of 93%. And the progression-free survival is 6 months as compared to 2 to 3 months, and objective survival rate of 22 months comparing with real-world data of 3 to 6 months in those failed systemic treatment. And just to extend our territory a bit further, this is a patient with CA prostate recent score of 10 and failed systemic treatment, 4 cycles of treatment show progression of disease and is not controllable by subacute leukocytes. Notice a PSA of SUV of 60.2 and was referred for salvage chemosaturation, where we selectively embolize a prostatic artery with small amount of epirovisin and cisplatin. And this is made possible by angio-CT guidance, showing that selective deposition of the chemotherapeutic drug just into the prostate, but not the other organs surrounding the area of interest. And with that, within 1 month, the tumor shrunk by 60%, and SUV at 15 months has decreased from 60 to 34.2, and the tumor size are also much smaller. So chemosaturation has actually expanded the capability of local regional tumor control. In a patient with polydifferentiated CA of tongue and DXT in 2018, which showed the local recurrent and failed surgical excision twice, failed third lines of systemic chemo, and the whole tongue was infiltrated with a huge tumor and was referred for an intervention because of intermittent massive bleed. Again, with super selective chemosaturation of the lingual artery both sides, we are able to densely deposit the chemo drug directly into the tumor, and with the combination of MVASI, 5-FP, cisplatin, and epirovisin in small doses. This is during first session, this is after the second session. And this is third session. You can see that the whole tongue was atrophic because almost 90% of the tongue was infiltrated by the tumor. And because of the tongue atrophy, yes, some difficulty in swallowing and some airway issue that we had to put the ETT, allow tracheostomy. So in summary, the future IO is on a hybrid angio-CT, which with the current new development in targeted therapy and immunotherapy, which reshape the landscape of oncological practice, we have to be more innovative and more new mindset in IR and IO. We really need a high precision, super selective target embolization to achieve a better clinical outcome. We have to institute organ sparing embolization protocol. We have to explore more combination therapy with targeted drugs and immunotherapy, and accept more complex intervention in order to survive in this field. And of course, angiographic Google Map guidance and target endpoints and 3D safety margins are the essential thing we need to ascertain on paper. And these are all available with the angio-CT system, and the capability is unlimited. And with the addition of 4 cm volume CT fluoroscopy at low dose is essential and pivotal, and this will be the minimum requirement when Canon want to sell the next angio-CT system. And with this, I would like to thank you for your attention.
Thank you, Alex. Thank you for your excellent lecture. And I have 1 or 2 questions. You raised many functions of this angiographic CT machines, but there are many. And what kind of function do you admire most? Please raise 1 to 3.
Number one, what makes the angio CT so good is the CT arm, is not angio arm. The CT arm which comes with volume CT fluoroscopy. The bigger, the better. Of course, Aquarian one is everybody's dream. I wish I can have the next machine of that. But for a bare minimum, the 4 cm detector row is good enough to do most of our work with a little bit of the inconvenience or limitation. All my works are done on 4 cm volume CT angiography. So I think we are a little bit trick in the application and functionality. We can achieve almost everything we want. Of course, the whole body perfusion using the Aquarian one will be ultimate role. Second thing is the software. I think Canon really need to catch up with other competitors in coming out with the state-of-art software in terms of AI, auto fusion, 3D setting margin analysis, and more perfusion study. I think this would complement and make the work much easier for us.
Okay.
Do I answer your question?
Okay. And we have Dr. You mentioned about strategies that Dr. Kudo proposed, and Dr. Kudo will come tomorrow to here. And I can tell him that you are complaining about Dr. Kudo, and is there something you want to tell him? Of course, we are fighting Dr. Kudo and about TACE and combination therapy. Tomorrow, he will tell about combination therapy of lenvatinib and TACE.
Okay, I think everyone should put the patient's interest as in front rather than what we can do. It has to be a multidisciplinary combination, combined effort and decision. IR can offer excellent services. Medical treatment also can offer medical excellent services. But I think we have to put objective evidence in front in order to achieve the best clinical outcome. Unfortunately, embolization is a skill-based exercise. Every one of us as IR has different protocol. Some do super selective, some should and go. So we do not see a uniform result. I have to apologize that the result you're seeing from what I'm doing may not be achievable by another IR. So we have to really put together our head and effort in standardize the standard of care and services in terms of chemoembolization. Now you are a president of APSCVIR. The task is on you to get this done so that all IR doing the same standard of care, all IR institute the 3D safety margin and adequate super selective embolization rather than non-targeted half-hearted job. On the other hand, if the 5 cm tumor or 7 cm tumor can be controlled with embolization with adjunctive immunotherapy or TKI, to me, I think we should control the beast first rather than trying their luck. You know, the systemic treatment TKI, the response rate, objective response rate is 29%. Immunotherapy, in our experience, is 30%. So their experience of 44% probably is very, very tightly controlled clinical data. So we have to be honest with them and with the patient that their failure rate is still 60 to 70% in most cases. So we have to work together, not trying to garner each other's field and claim the patient belongs to them. This is my honest opinion. We have to work together with them, and they have to work together with us, not telling everybody they can do better than us. Be honest. Thank you.
Yeah, thank you. So thank you, Alex. Give him a big hand, please. And
Thank you.
thank you. And it's time to wrap up this session. Thank you very much. And I appreciate Canon to have this session. Thank you very much.